This is my client with chronic pelvic pain, and I'm going to let him give us a little bit of history and tell us about the treatment that he's received. And he lives in the same city as I do, Aurora, Colorado, and his father did some online research and found that I work with pudendal neuralgia. And he's home from college, and I'll let him tell us a little bit about his history and treatment.
Well, I have been having these sort of pelvic pain problems since around 2011. Initially, they started out as really sporadic events, probably maybe once every 4 or 5 months. I would get the feeling that I hadn't completely emptied my bladder and experiencing some, burning when I urinated. And then around 2014, something happened, and when the feeling became permanent and it became more intense. So there was kind of a constant feeling like I was sitting on something, pressure in the sort of undercarriage and perineum, as well as more pain with urination. And that's been going on pretty consistently since then.
And you've had some treatment, and it seemed related to a fall when you were skateboarding?
Yeah, that was, so the initial treatment that I sought was in Boulder. There was a pelvic pain clinic which specialized in this sort of non-bacterial prostatinia that I had, and they said that the most likely cause would be a fall from the skateboard that I had that summer, which would have been on my tailbone or something like that. So they'd given me some stretches to do, some internal trigger point release therapy, as well as external with injections, and none of it really seemed to work or do anything.
And you were diagnosed with pudendal neuralgia?
I was not, no. Not
No?
officially diagnosed, no.
Okay. All right. It's just the pain distribution caused you to wonder about that, am I correct?
Yes, 'cause my dad had a friend who had very similar symptoms, and this route had seemed to work for him. So since we had not found anything yet, it seemed like a good next place to stop.
Okay. Well, I'll cover some of the findings. You have a little bit of asymmetry in the development of your hips, which I think is no big deal, except with respect to your lower extremities. Your left leg is shorter by about 3/4 of an inch. And I'm going to show the orthotics. So this is the orthotic he uses in his left shoe for hyperpronation. And I'm the video guy, so I'll keep checking and make sure we have a good image. And then if you look at the orthotic on the right shoe, and you look at under the shoe, so here's his wear pattern, little bit of wear here, but not a lot, okay? And then you contrast that to the right shoe, a little bit of wear here, but a lot of wear up here. And in the course of less than a year, you really chewed up this orthotic, didn't you?
Yeah, and I get chewed through shoes too, like
Look
that.
at that.
Socks, it's all the pattern. You can tell if it was mine and been on my feet. So.
That's incredible. That's absolutely fascinating. So we have to ask ourselves, yes, it's pelvic pain, but we have to look at the whole body and give consideration to more than just the pelvis. And again, he has a leg length difference of approximately 3/4 of an inch. And because of that wear pattern of the shoe, I think that a heel lift in the left shoe would help, but the tolerance is usually only 1/4 of an inch. And I therefore think that it's worthwhile to try a built-up shoe and see what that does. I screened his feet and ankles, and other than hyperpronation on both sides, there was no motion deficit that was treatable. There was no, one-sided dysfunction in the ankle joint or the subtalar, etc. Okay? Now I'm going to focus on the pelvis a little bit more now. Due to the leg length difference, he functions with a side glide fixation of his pelvis. That's how he compensates unconsciously. I cannot move the pelvis from the left to the right with a reasonable amount of force. And so I call that a left side glide pelvic fixation. Notice I can take up the slack readily, shifting pelvis from right to left, and then I can thrust it a little more, give it a little bit of a spring, and it moves. Now, when I try to rotate the pelvis posteriorly, emphasis on the right side, there's no give at all. When I try to rotate pelvis on the left, I can take up the slack, but then it takes up so quickly and then it doesn't move. Let's have you lie on your stomach, please. He does also have greater resting external rotation of the right hip. On the left hip, he has no hip extension. Let me check that camera angle. And on the right hip, he extends about 10 degrees. Moving into 15 degrees. So we certainly want to restore hip extension on the left, and I think that we could stretch the right and gain a little bit. It felt a little tight on the right. The pelvis is fairly symmetrical, but remarkably, the sacrum is very posterior. Let me make sure that camera angle captures this. So I think there are several orthopedic issues that need to be addressed as part of the overall consideration of his chronic pelvic pain. So I'm on his PSIS on the left. And now I'm going to put my thumb on the sacrum, and the sacrum probably obscures it from the camera angle. I'll show you the right PSIS is right there, and here is his sacrum. His sacrum is very posterior, and it's stuck in posterior glide. This is a pattern I discovered and developed treatment for it, and there's just no give, no spring on that sacrum. Now when I try and create inferior glide of his ilium, it doesn't move. It doesn't move on this side. I'm putting a reasonable amount of force, and there's no superior glide. And there's no superior glide on this side. The sacrotuberous ligament is right here, and it feels like bone. But there is no bone in this area. I can't indent that ligament. And it's very, very tight because that sacrum has come posteriorly. The posterior positioning of the sacrum will certainly create tightness in the pelvic floor that's not going to respond to internal pelvic floor work. The pudendal nerve traverses between, there's a long trajectory, and it winds around and does go through the sacrotuberous and the sacrospinous ligaments. So maybe if we can create normal tone in those ligaments by repositioning sacrum and hemipelvis on both sides, maybe we can take tension off of that, or compression and tension off of that nerve, and over time maybe that can heal and reduce symptoms. The other thing that I find is I come and isolate the coccyx, and I come on both sides into the sulcus, and he's got a deeper left sulcus because he has a left side bent fixation of the coccyx. And so if you look at the sacrococcygeal ligaments, you look at the sacrotuberous and sacrospinous ligaments, they all have a little bit of insertion onto the coccyx, and that side bending deviation is certainly going to affect tension more on one side than the other of the pudendal trajectory. So we have some interesting findings from an orthopedic perspective. And what we find in the upper cervical spine is that his occiput does not have accessory motion into right rotation. and it doesn't have right oblique rotation. And the atlas, the top C1 vertebrae, is in right rotation and it lacks left rotation. And that's a compensatory pattern to what is going on in the lower extremities, the leg length difference. That's a reflex phenomenon, and it's very hard to treat a reflex locally if we correct the leg length difference. And I think that upper cervical will be a lot easier to resolve. So this is a summary of my findings, and I think again that there's an orthopedic contribution that needs to be dealt with, and to find out if it contributes to his overall symptoms. And we will begin treatment, and we'll film response to treatment later on. Thank you.